Assalamu alaikum, Bismillahirrahmanirrahim. So the next presentation we will be doing is the transport of critical illness. And this is really important presentation because I want all of you to be attentive. You're going to be shown different videos in this presentation, and you're going to see how effective communication can change the outcome, and why it is important that the clinical presentations or communication is how it is very important in these cases, especially.
Pediatric intensive care unit, this is Dr. Duncan. How can I help you? Like he is in shock and we need to work on getting him stabilized and getting him transferred to a higher level of care. What are the capabilities for stabilization as well?
And we can be reached here at 972-981-7. He appears lethargic and confused to me. He's also got this diffuse petechial rash over his lower abdomen and lower extremities. His extremities are really cool to touch. We've got some labs drawn, but we're trying to get a better idea.
Some electrolytes. If you could draw off a blood culture as
Let's start. So next please. So the objective of this presentation is to describe the communication process for safe and effective transport of critical ill child, specify the information from the referring institution and accepting hospital. It should be provided to the transport team to facilitate stabilization and timely transfer. Basically, usually there is a separate transport team in the US where they usually transport patient from the referring hospital to the accepting facility. And that concept has been given here, but you are going to understand if you are accepting the patients, what are the things that you need to ask from the accepting facility and how you can help them in managing these kind of critical ill patients. Describe monitoring and equipment for intra and inter-facility transport. It is not mandatory that it is between the hospitals. You must have transported the kid within the hospital to the radiology department or to the other department for any investigation, CT scan, MRI, and other investigations. It's really important from that point of view as well. Identify the factors which influence the team composition and mode of transport. Outline problems and complications that can occur during the transport. Next, please. So the first case is 10-year-old boy who walks into an emergency department with fever. He is tired and feeling dizzy. He asks to lie down. His heart rate is 175 beats per minute. Temperature is 40. He's tachypneic with respiratory rate of 34. Blood pressures are on the lower side. While lying down, he becomes restless and complains of nausea. He has diffuse petechial rash that covers his lower abdomen and legs. And capillary refill time is 3 to 4 seconds in his lower extremities. Next, there will be a video. Please closely listen to that video. There will be an accepting facility as well as there will be a referring facility. What conversation do they have? Closely note down the points and we will discuss. Next, please.
Pediatric intensive care unit, this is Dr. Duncan. How can I help you?
Hi, Dr. Duncan. This is Dr. Skranka. I'm here in the emergency room with a 10-year-old white male who was just brought in by his parents about 10 minutes ago. He looks pretty sick to me and we may need some help over here. The mother states that the child has had fever today to 101.3 degrees. The child's complaining of feeling dizzy and looks real tired. The parents basically say he just doesn't look right. In the ER over here, we've got a temperature of 40 degrees, heart rate of 175, respiratory rate of 34, and a blood pressure of 70/35. He appears lethargic and confused to me. He's also got this diffuse petechial rash over his lower abdomen and lower extremities. His extremities are really cool to touch. We've got some labs drawn, but we're trying to get a better IV on him now, and we're going to give him some fluids, but I really would like to get him out of the ER here.
All right, Dr. Skranka, it sounds like this child is quite ill. Certainly what you're describing and given his vital signs, it does sound like he is in shock, and we need to work on getting him stabilized and getting him transferred to a higher level of care. What are the capabilities for stabilization at your institution?
Well, we can give him IV fluids. I can give him antibiotics, of course. I've got oxygen capability, but we're really not used to taking care of very sick children like this. We're just a rural facility.
Okay, not a problem. Before we go any further, Dr. Skranka, can you give me this child's name and his weight, as well as a contact number in case we get disconnected?
The patient's name is John Whiteman. He weighs 32 kilograms, and we can be reached here at 972-981-7474.
All right, Dr. Skranka. Now let's talk about getting him stabilized. One thing I think you could do to help him out, I know his saturations sound like they're okay, but if you can just go ahead and put him on some supplemental oxygen, that will help him in a state of shock. I agree with getting an IV in him. In fact, if you're not able to readily get quick IV access in him, I would consider putting an intraosseous line in if that's something you're comfortable with. And once that's done, start with 20 cc's per kilogram of either normal saline or LR. And if his perfusion, heart rate, vital signs don't improve, I would go ahead and repeat that bolus one, if not two times, up to 60 cc's per kilo. And if that doesn't help, I would even consider starting some dopamine at 5 to 10 mics per kilo. It sounds like you're on the right track getting some labs. I would just go ahead and check a bedside glucose as well as some electrolytes. If you could draw off a blood culture as well, and then I would give him some broad spectrum antibiotics such as cefotaxime or vancomycin, given that this sounds like an infection. If you can, please be sure to let the family know that, how quite ill their child is, and explain to them the benefits of transferring their child to a pediatric hospital to receive a higher level of care. I would be happy to accept him in our pediatric intensive care unit. Is there anything else I can do for you?
That sounds great, Dr. Duncan. My only concern is he looks pretty sick, and I'd really like to get him out of my ER. I've got a hospital-based medic unit here that can go at any time, and I'd like to know if I can go ahead and activate those guys.
Well, Dr. Skranka, given how critically ill he is, I think this child would benefit much more from a pediatric subspecialty team coming to pick him up. They are trained at the stabilization and care of kids just like this, and really his intensive care therapy can start from the moment they arrive. So let me give them a call to try and expedite this transfer. If you can obtain consent from the family, I'd appreciate it, and I will call you in a few minutes once I've been able to arrange this transport.
That sounds great, Dr. Duncan. I appreciate your help, and we'll give you a call back if we need any further assistance.
All right, I'll call you back soon. Thanks.
So, what you have observed in this interaction? Communication. Seek for help. That the help has been advised on telephone to the accepting from the accepting facility to the referring facility, and how to manage this child. All right. What other important pertinent points? Very good. That's very good. What other points you have noted down in this?
The initial management of this
Initial management. Very good.
the doctor was assisting that very like to be able to cover.
Good. Yes. Exactly. Another important thing that we must have noticed that the accepting facility doctor asks the name, age, weight, where he is from, and what are the demographics. How much it is going to take for him to reach here and all these, because that is really important. And he had asked where he is right now. He is in the ER, he is in the OR, he is in the ICU, where in that hospital. Because अगर आप transport नहीं कीजिए तो आपको किस जगह पर भेजना है. And he had taken the contact number. अगर बीच में line disconnect हो जाती है तो he will be nowhere. He will have nothing to contact back. So these are really important things जो हम ignore करते हैं. And we don't put the stress on those. So, interaction, what factors include safety and patient outcomes during transport? You can select mode any one or more than one of them. A, B, C, D, okay. So it may be D because use of technology and advanced communication devices is not required during the transport. Which may be other important things, that is pre-hospital stabilization is quite important. Early communication with the reference center and determining appropriate team composition, equipment and monitoring and mode of transport is very important. Next, please. So communication is the key. Initial referral report, जैसे कि हमने इस वीडियो के अंदर देखा, obtain essential information, provide referral facility advice on stabilization, determine mode of transport in consultation with the referral center, and give reference center estimated arrival time for the transport team. Physician to physician communication is very important. They must be clear and it must be informative. Communicate any delays in the transport if there are any delays. Request the copies of medical record, laboratory results, and radiographic studies that should accompany the patient during the transport. क्योंकि आपको फिर डबल चीजें नहीं करनी पड़े, वहाँ पे अगर एक्सरे हो चुका है, सीबीसी हो चुका है और दूसरी लैब्स हो चुकी हैं और उनके पास लैब्स मौजूद हैं and it is being accepted in the accepting facility, and why you would going to repeat the other labs which are already done. Next, please. So, inter-hospital transport initial information should include patient identifying information. That should be the initial thing that you should ask. And what is the identifying information? इसका कोई MR number है, बच्चे का कोई hospital file number है, या एज क्या है, बच्चे का नाम क्या है, बच्चे के वालिद का नाम क्या है, हो सकता है उस नाम के दो बच्चे याद के अंदर मौजूद हो. So you need to make sure that you need to have proper identification number for that patient. रेफरेंस फिजिशियन, रेफरेंस फैसिलिटी लोकेशन, रेफरेंस फिजिशियन का नाम आपको पता होना चाहिए, रेफरेंस फैसिलिटी का नाम और वहाँ किस लोकेशन के ऊपर है और उसकी कॉन्टैक्ट नंबर, वहाँ का कॉन्टैक्ट नंबर. Brief summary of the patient condition, physical and vital signs, physical examination, relevant laboratory and radiological results, and major intervention performed and patient's response to those interventions. अगर उन्होंने कोरस किया तो उससे क्या फर्क पड़ा है, repeat vitals क्या है. Next. Referring hospital responsibilities are they have to stabilize the patient before they are going to move the patient to the accepting facility. They should secure the airway and vascular access should be there. They should have PIV. अगर PIV नहीं मिल रही तो they should have an intraosseous line so that they can give emergency. Airway should be secured if they are not being able to maintain the airway and should be integrated. If the patient needs higher level of care, initiate the transport or to the accepting facility. Notify the family and obtain consent for the transport, copy reports, radiological studies, transport summary, and medical list, and that results should be provided, and provide transport with the telephone numbers for pending lab and study reports. Next, please. तो इमरजेंसी डिपार्टमेंट इंटरवेंशन जो कि हमने इसमें देखे, इन्होंने फ्लूइड इस बच्चे को जो है फ्लूइड वॉल्यूम मिला 60 ml पर kg से वॉल्यूम मिला, ब्लड प्रेशर ट्रैकिंग इंक्रीजमेंट to 80/35, capillary refill is still prolonged, patient has episodes of desaturation 75% by pulse oximeter despite increasing of IL2 to 1, 100% via the non-breathing face mask, and the patient is now lethargic with slow irregular breathing. What do you think the child is developing and what intervention should be done? Child is having low saturation. Child is having poor capillary refill. Blood pressure are on the lower side. He is in a state of shock. He is having respiratory failure and in decompensated shock at this point in time. Retarded and slow irregular breathing in respiratory failure. So you will going to what you are going to do? Intubate करेंगे, volume resuscitation करेंगे, and inotropic support. Very good. क्योंकि 60 ml पर kg सभी आप दे चुके हैं. And what should you communicate with the accepting facility? अभी तक तो उनको पता ही नहीं था बच्चा इंटूबेट हुआ है. तो अगर आप नहीं बताएंगे तो they will not going to arrange ventilator for the transport या और चीजें जो और आइनोट्रोप्स आप स्टार्ट कर रहे हैं वो उनको बताना जरूरी है कि ये बच्चा आइनोट्रोप पे चला गया. So that they can come with the infusion pumps, they can come with the medications which would be needed to the transport of this child to their to the accepting facility. Okay. Okay. This is a video in which we are going to communicate with the transport team what needs to be done. Sorry, this is the accepting facility. Can you go back, please? So this is updated information. Back again.
It's Dr. Skranka.
Yeah, this is Dr. Duncan at Sims Regional Hospital. How are you doing?
Well, he's stable, but I'm kind of worried about him. He's on his third normal saline bolus. We've got antibiotics hanging. I did start low-dose dopamine to improve his perfusion, but because of his depressed mental status, I went ahead and did a rapid sequence intubation on him, and we're ventilating him right now. I'd really like to get him out of the ER as soon as we can.
Well, again, based on the severity of illness, I still think he would be better serviced by our pediatric subspecialty team coming to pick him up at your facility. Since you all are a little over 100 miles away, I've begun arranging a helicopter transport, which I feel will be the most appropriate. Our pilots are checking into weather, and hopefully we should be there soon.
That sounds fine. My only concern about that is my charge nurse informed me that we've got a front coming in. I'm a little concerned about the weather. Do you think that's going to delay your arrival?
Well, it shouldn't cause a delay in us getting there, even if we're able to just fly our team there and get them involved. If they have to come back by ground, if weather moves in, that's not a big issue. Again, this is what they're trained to do. They're trained to continue the stabilization and really the intensive care therapy of this patient until he arrives here at our facility. Some other things you could do for me, it sounds like you've done a great job taking care of the patient, and I would continue doing what you're doing, but if you can have your staff copy the chart, please send us all copies of his labs and x-rays, as well as if you could even jot down a brief transfer summary, I would appreciate it. I'll have our administrator call your hospital administrator for approval. Please feel free to put me down as the accepting physician. Again, I'm Dr. Duncan. Our transport team will be calling your charge nurse shortly with an estimated time of arrival. If this kid's condition worsens in any way, or you just even have a question about what to do next, please don't hesitate to call while we're en route.
Well, that sounds great, Dr. Duncan. I appreciate all your help, and if there's any change in the patient's condition, we'll be giving you a call back.
All right. Thank you very much. Bye.
So, similar thing which we have discussed in the last few slides. So, what factors influence the mode of transport between the facilities? It is the distance between the hospitals, diagnosis and severity of the patient, local geographic characteristics, weather and traffic patterns, transport team capability, and scoop and run to the nearest facility. A to D, very good. That's correct. Next. So all of these four are correct, except the last one. First have to stabilize the patient before the patient has to be transported. Otherwise, the child might die during the transport. So it is really important to stabilize the patient. The other transport of vehicles, it depends. Ground transport होती है, fixed wing होती है, helicopter होता है. Fixed wing means aeroplane, and ground transport means ambulance, and helicopter goes to those areas जहाँ पे road नहीं है. For example, in hilly areas, अगर KPC में कोई ऐसी जगह है जहाँ पे कोई एम्बुलेंस नहीं जा सकती, पहाड़ के ऊपर है, तो it is that is the mean of transport that is usually used. There are different sort of things. Availability, ground transport is excellent, कि हमारे यहाँ भी available है, एम्बुलेंस हर जगह available है. Fixed wing इतनी ज़्यादा availability नहीं है. Helicopter is not that good as well, but in the southern areas it is there, and I'm checking after it. Safety issues के point of view से ठीक होते हैं. Civil environment के point of view से definitely ground ambulance की इतनी अच्छी civil environment नहीं होती. Fixed wing के अंदर थोड़ी बेहतर होती है. Helicopter के अंदर very poor होती है, कि बहुत limited space होती है जिसके अंदर उन्हें काम करना होता है. Time of transport ground के अंदर ज़्यादा होता है. Helicopter में जल्दी पहुंच जाते हैं. Fixed wing के अंदर ही it's pretty good. Range अगर 100 miles से below है तो definitely ground ambulance is recommended. If it is between 200 to 2,000 miles, definitely fixed wing is recommended, and if it is between 100 to 150 miles, helicopter is recommended. And in this, there are some special issues, road and weather conditions. अगर ऐसी है कि ambulance नहीं जा सकती, flooding हो रही है, so one can move on to the other areas as well. Or fixed wing के अंदर there are multiple transfers. It is not mainly सिर्फ अपने जहाज को बुक करना होता है। हॉस्पिटल से एयरपोर्ट जाएंगे तो उसके लिए एम्बुलेंस करनी है, फिर उधर से एम्बुलेंस से they are going to go into the एरोप्लेन से फिर एयरपोर्ट पे उतरेंगे, वहाँ से एम्बुलेंस आपने अरेंज करनी होगी टू द अदर एक्सेप्टिंग फैसिलिटी। So it requires multiple transport. So there are pros and cons of each and every transport. Next, please. Accepting facility की जो responsibility होती है, accepting physician should be there, bed assignment आपने करना होता है before transport। ऐसा नहीं आपने accept कर लिया और bed ही नहीं आपके पास, फिर कराने का फायदा नहीं है। You have to then transfer into other facility. स्पेशलाइज्ड डायग्नोस्टिक और थेरेपेटिक मोडालिटीज आपके पास वो अवेलेबल है जिसकी पेशेंट को रिक्वायरमेंट है, अगर नहीं है तो आप उसी पर यूज कर सकते हैं। स्पेशलाइज्ड ट्रांसपोर्ट टीम आपके पास है या नहीं है, अगर नहीं है तो यू कैन आस्क सम हेल्प फ्रॉम द अदर ट्रांसपोर्ट टीम्स इन दिस। इज दिस एन एप्रोप्रिएट रेफरल दैट वी हैव डिस्कस्ड? आपके पास वो सारी फैसिलिटीज हैं। नेक्स्ट, इज देयर इज अ बेड अवेलेबल? What intervention are recommended through the referral center, and what is the appropriate mode of transport for this patient? So, last item we can discuss. Next. So now,
Hey Joyce, we need to send the pediatric subspecialty team to.
So, transport team से क्या communication हो रही है वो आप
Hey Joyce, we need to send the pediatric subspecialty team to Southwest Hospital. They have a 10-year-old little guy who showed up there with what sounds like septic shock. He's already been intubated, he's gotten lots of fluids, they've actually already started him on a dopamine infusion. You guys are going to be able to probably fly out there, but there is a weather front coming in, and so you may have to drive back.
Okay, what other medications and equipment do we need to facilitate this transport?
Well, you definitely need to take the ventilator, and I would probably make sure we take enough oxygen and gas to make sure that we can come back by ground if we have to. He's already gotten his antibiotics, so we don't have to worry about that, but I would go ahead and mix up dopamine and then probably even an epinephrine and norepinephrine infusion. Take enough fluids that you can give him some ongoing volume resuscitation if he needs it, as well as pumps to be able to titrate his inotropes. If you don't mind giving Dr. Skranka a call when you guys know an ETA, I'd appreciate it.
Okay, we'll be leaving for Southwest Hospital in about 10 minutes.
All right, great.
Okay,
Thanks.
So what you have seen now, things that are needed for the transport, what are the anticipated things that the child might need during the transport, and these are the things. Name, and he has mentioned about the name, patient demographics, and the location kahan pe hai. Contact number should be given to the transport team. And receiving physician name is important. Weight, vital signs, working diagnosis, transport vehicle and team composition, equipment required or anticipated, and patient status including completed and planned interventions. Next, please. Next. So, what basic level of monitoring equipment is required for the transport of critically ill children? Electrocardiogram, pulse non-invasive patient monitoring, oxygen laser and oxygen tank, defibrillator with battery backup and transporting the patient, and WCD. Almost all of them. Next, please. Just only entire CO अगर है तो ठीक है, नहीं है तो फिर भी चलेगा, because you will be able to see it sometimes in the ventilator, or sometimes you will see the chest rise and you will be able to see that the chest is chest sheet. So it's not mandatory, अगर है तो अच्छी बात है, necessary नहीं है, but बाकी सारी चीजें necessary है for the transport of these kind of critical. Next, please. So equipment, cardiopulmonary monitor, ECG, heart rate, non-invasive blood pressure, pulse oximeter, defibrillator, infusion pumps, होने चाहिए, better mask ventilation with appropriate size face mask, oxygen analyzer and oxygen tank, ventilator capable of infant, pediatric or adult modalities, and portable suction unit. So that if there are any situations during the transport, we can suction this to. Next, please. Personnel, it depends, dictated by the individual facilities and resources available. Clinical condition impacts the team composition. अगर for example बच्चा intubated नहीं है, सिर्फ inotropes के पर है, तो हो सकता है कोई नर्स भी लाके लेके आते हैं, उसके लिए स्पेशलाइज्ड नर्स की जरूरत नहीं होगी। लेकिन अगर बच्चा intubated है, डेफिनेटली इसके लिए आपको स्पेशलाइज्ड टीम चाहिए होगी, वेंटिलेटर भी चाहिए होगा, और ऐसी नर्स चाहिए जो वेंटिलेटर पे बच्चे को देखें। necessarily after some procedure. Emergency medical services, ambulance, or nurse practitioner, or broad-based critical care team या specialized pediatric critical care team. कभी कभार होता है pediatric critical care team नहीं है ट्रांसपोर्ट की, हो सकता है adult बच्चा थोड़ा सा बड़ा है तो adult लेके आ जाएगी या adult critical care team से सामान लेगी. These are the things. It depends on the availability of specialized personnel who are available for transport. Next, please. So now,
Pediatric ICU, this is Dr. Duncan.
Dr. Duncan?
This video is mainly about the transport team has reached the hospital, Grafton Hospital, and they're going to give feedback to the accepting hospital that they have reached here. And after they have examined the patient and assessed the patient, they are giving feedback or to accepting facility that they have reached here, what's the condition of the patient, and anything else they wanted to do in the management of the patient. All right. Please.
Pediatric ICU, this is Dr. Duncan.
Dr. Duncan, this is Joyce from Transport. We are here in the ER at Southwest Hospital with a 10-year-old child with a petechial rash and septic shock. The child is intubated with a 6.0 cuffed ET tube that is secure and in good position by chest x-ray. The most current vital signs show a heart rate of 145 beats per minute, blood pressure 110/60, respirations of 18 breaths per minute. We have placed him on our monitors. He is sedated, pupils react, and he does arouse to stimulation. Good heart tones and lungs are well aerated. His abdomen is soft. His pulses are improved in his distal extremities, and cap refill is about 2 to 3 seconds. He is still somewhat cool peripherally. Our ABG shows a pH of 7.35, PCO2 of 45, and a PO2 of 90 on our transport ventilator on an FiO2 of 100%. We've got a rate of 18, tidal volume of 8 mils per kilo, and a PEEP of 6. All lines have been secured, and a Foley catheter and oral gastric tube have been placed. We have IV fluids running at maintenance, and the child is on epinephrine at 0.5 mics per kilo per minute, and dopamine running at 7 mics per kilo per minute. We plan to keep the child sedated with fentanyl and Versed for transport. His urine output has only been about 0.5 mils per kilo per hour. We'd like to give the child another fluid bolus. Is there anything else you'd like for us to do before coming back?
Oh, I agree. Go ahead and give him another 20 mLs per kilo of either LR or normal saline as a bolus. It sounds like you've done a great job. If you can remember to bring back a copy of the chart, all the labs, as well as any x-rays that have been done. If you can get a contact number from the parents so that we can contact them if anything happens or his condition worsens, that'd be great. Please tell Dr. Skranka thank you for the referral, and if you need any further assistance or his condition changes, please don't hesitate to call. What is your ETA?
Our ETA to your facility is approximately 2 hours.
All right, no problem. We'll see you soon.
So what have you seen in this video? All right. What other things you have noticed? Very good. Great. Any other thing you have noticed?
Expected time of arrival.
Exactly. Time of arrival. What is the key to the acceptance facility so that they will be prepared, well prepared before the child was going to arrive. For example, अगर इस बच्चे को किसी सर्जरी की जरूरत है या किसी और सब स्पेशलिटी की जरूरत है तो we are going to inform them beforehand that this patient is coming. We are going to be there in 2 hours. अगर सर्जन को कहीं से बुलाना है वो in hospital नहीं है, we will arrange for all these needs and duties so that once the patient will going to arrive in the acceptance facility, the things will gonna go right away. All right. So, transport team responsibilities: communication of the patient information, personal team composition, medical information, monitoring and equipment, and medication. Next, please. Legal consideration is really important. Interprocess transport should be from a lower to a higher level. Transport should ensure that the patient arrives in a stable and improved condition. Be aware of logical, regional, and national laws regarding the interfacility transfers. Financially motivated transfers are center, and best practice requires informed consent prior to inter-facility transport. The parental consent is next, please. Pitfalls are perform interventions to stabilize pediatric patient before transfer to prevent clinical deterioration, provide appropriate equipment to accompany the patient during inter or intra-facility transport, and equipment and medication for stabilization must be available for at least 30 minutes beyond the expected time of transport. For example, इन्होंने 2 घंटे का अगर बताया तो उनके पास 2.5 से 3 घंटे का इक्विपमेंट हो के बीच में अगर कोई रश मिल जाता है इन्हें एम्बुलेंस के अंदर या और कोई इश्यू हो जाते हैं so they will be able to handle them. Next, please. Key points are perform interventions to stabilize pediatric patients and prevent clinical deterioration during transport. Transportation only when sufficiently stabilized to allow safe transport. Provide information to determine optimal mode of transport and establish early contact with the receiving facility to ensure most experience patient transport. Next. Copy of medical records, laboratory results, radiological studies, and whom contact numbers for the reference center and family before transport if possible, and communicate any changes in clinical. Thank you. If you have any questions, we will going to do question and answer during transport. Discuss station will going to move toward the next presentation.